Everyone, thank you so much for joining us in Medicine Grand Rounds. My name is Evangeline Galvez, and I am the program director, the residency program director of the Internal Medicine and Pediatrics Combined Residency Program. It is my pleasure to present our speaker this morning. Dr. Alison Schwartz is a graduate of Tufts University for both undergraduate and medical school, and she was with us here for the last she was here for her residency and was one of our incredible residents and finished her residency career as ambulatory chief resident of the Department of Medicine. She has pursued her passions in primary care and championing for those pediatric patients with special needs as they transition into adulthood. And she's assumed the position as a primary care physician at Everett Clinic Family Care. In addition, she serves as the co-director of the Adult Down Syndrome Clinic. So I'd like to present Dr. Alison Schwartz.
Thank you. So good morning, everybody. So do these numbers resonate with anybody? So 25 was the average lifespan for an individual with Down syndrome in the 1980s. Let's make sure this actually works. And 60 is the average lifespan that we quote today for individuals with Down syndrome. So that's a pretty impressive leap in medicine. And because of this, there are more and more adults with Down syndrome who are being seen in primary care practice as well as subspecialty practice. So over the next 45 minutes, we're going to be talking about the adult care of individuals with Down syndrome. And as Dr. Galvez says, I'm the clinical co-director for the Down syndrome program, where we see individuals of all ages, so 0 to elderly. And I do this with my colleague, Dr. Brian Scacco, as well as a really robust team, which I'll introduce later. So I want everyone in the audience to know about our clinic so that we can help serve you and your patients and their families. But secondly, like many of you in the audience, I'm a primary care doctor at heart. And I've learned that one of my favorite parts of medicine is practicing and working with individuals with Down syndrome and their families. It's an incredibly rewarding patient population to work with. So my hope is that this talk will leave you with a greater understanding of how special these individuals are, and you look forward to welcoming them into your practice. So the obligatory disclosure slide is that I don't have very much to disclose. I do volunteer in a non-paid capacity to the MASH Down Syndrome Congress. So for the rest of the talk, we're going to kind of talk about Down syndrome basics just to make sure we're all on the same page. I wanted to mention some of the advances in prenatal diagnostics because this has been in the news recently. We'll go through 4 case vignettes that really highlight a lot of the medical issues that individuals with Down syndrome struggle with. We'll do a virtual tour of the Down syndrome program, and then we're very fortunate to have our resource specialist, Ben Majewski, who has Down syndrome. He's going to talk to you at the end about his life and his experience in working with our clinic. So this face is probably familiar. This is Dr. Jose Flores. He was the founder of the clinic in 2006. So his inspiration was that he has a sister with Down syndrome, and he felt like he wanted to create a medical home with consultative primary care and subspecialty care, where individuals could be seen by specialists who are well-versed in the medical issues related to Down syndrome, as well as the psychological issues and the overall lifespan of somebody with Down syndrome. So initially the clinic was just seeing adults and some young adults. But over the last year, we've really expanded, and now we have 5 different clinics, and we see individuals from 0 until elderly. So this is our current team, some of the team members, which ranges from social worker to research to speech and language pathology, audiology and ophthalmology, as well as numerous physicians. All right. So Down syndrome comes in 3 flavors. You've probably learned this all in medical school. Trisomy 21 is the most common. This is seen in 95%. It's due to meiotic non-disjunction. Most of the time it's due to the maternal gamete. However, there's a small percentage where it's the paternal gamete. The next flavor of Down syndrome is translocation Down syndrome. This has important implications for future pregnancies. So translocation Down syndrome is seen in 4%. If you were to look at the parent, you would see that they have a balanced translocation where they have the 2 copies of 21. However, one of the copies of the 21 is linked to another chromosome, often chromosome 14. And then when they go on to reproduce, the child has 3 copies of 21 with one of them attached to 21. So we always suggest that people have a karyotype so we can understand whether or not they're at an increased risk for having another child with Down syndrome. And lastly is mosaic Down syndrome, which is seen in 1%. And this has a variety of different phenotypes, but in general, we treat everybody the same and use the same guidelines because we never know how they're going to present. So Down syndrome is the most common medical genetic diagnosis, and we're all very well trained in the typical phenotypic facies, so most people can recognize somebody with Down syndrome as well as their short stature, intellectual disability, and their increased risk for lots of medical conditions, especially in childhood, such as leukemia and congenital heart disease. However, the part that we don't really learn about until you're actually working with these patients in clinic on a daily basis is that they are some of the wittiest and kindest and most loyal patients. They also have an extreme talent for music and art. So this past Tuesday, I had a 5-year-old in clinic who basically spent the whole entire time with her little phone dancing to the Beatles song, Here Comes the Sun. And everybody that came into the room, she grabbed their hand and said, dance. I also have an adult patient who's 40 who is in liturgical dancing, which was something I didn't know very much about, but he informed me that liturgical dance is a kind of dance of worship. So they do it in churches and whatnot. And this was written about him. We'll call him Mike. So this is from the Boston College Chronicle. They say, one dancer, Mike, who has Down syndrome, joined the company several years ago in a way that is particularly poignant and memorable. Apparently, he was praying for some sign from God so he could use his music and dance talents. Mike has an intuitive, instinctive performing ability. He's been such an incredible joy and teaches all of the dancers something about the quality of performance, letting it really come from the heart. It's not all about technique. In addition, individuals with Down syndrome are very determined and they have a lot of perseverance. And lastly, there is a decreased risk for some medical conditions, such as myocardial infarction, despite some of the same risk factors like high cholesterol and obesity, and a decreased risk in solid tumors. So as I stated before, individuals with Down syndrome are living longer due to medical advances. So congenital heart surgery repairs are one of the main advances, as well as treatment for childhood leukemia. But again, you can see this is from a Swedish national registry, but it's similar to the data we have here in the United States. But in 1980, people were living into their 20s, and now people are living upwards of 60 years of age. But more importantly, people are living longer and fuller and rich lives. And so the advances in medical care have resulted in people surviving their childhood medical conditions without a lot of morbidity and mortality. But in addition, there are things like early intervention, which is a program available for children with special healthcare needs from ages 0 to 3. And early intervention provides physical therapy, occupational, and speech therapy to help them kind of catch up and really get prepared for school. Augmentative communication is a wonderful thing that's available for patients who have some trouble with expressive and receptive language skills. Individuals with Down syndrome often have excellent receptive language skills. They can understand things very well, but they might struggle with expressive language due to stuttering or speech impediments. So augmentative communication provides them a way that they can communicate without feeling frustrated. There have been tremendous improvements in education. So the Individuals with Disabilities Act was approved in 1990. So now all individuals are included in the least restrictive environment. So we see kids with Down syndrome as a part of a regular mainstream classroom. And vocational training has also become a big area that we push patients for when they are exiting out of high school at around age 22. It's really important to find some kind of vocational training or support program so they can continue to develop and feel a part of their community. And then lastly, we're really lucky in Massachusetts to have support from local organizations. So there's the Mass Down Syndrome Society as well as the local ARC, which has lots of resources that connect families and bring families together. So a few more statistics. So right now, 1 in every 830 children is born with Down syndrome. About 250,000 families have an individual with Down syndrome, and around 4,700 children are born every year with Down syndrome. The number I want you to focus on is this 250,000, because the CDC starts classifying something as a rare disease around 200,000. So it's interesting to note that what was once the most common genetic condition is now at risk of becoming a rare condition. All right, so this talk would not be complete without mentioning this, which was in the news last week. There was a question of Down syndrome being cured. The original paper was from Nature, which is translating dosage compensation to trisomy 21. And the Boston Globe says, in a laboratory dish, researchers shut down an extra chromosome that causes Down syndrome. So again, I'm not a geneticist, so this is how I think of this. But basically, you have Females have 2 X's, and one X here is depicted by this blue circle, which is the bar body, the X that kind of shuts off. So there's a gene that is responsible for silencing this extra chromosome here, because we don't need all of the material from both X's. So the scientists responsible for this basically said, if we can identify this gene and put it into the cells that have the extra copy of the 21st chromosome, maybe we can silence that. So that's what they did. They took a cell that has 3 copies of 21, they inserted the gene, and voila, they silenced this extra 21st chromosome with leaving 2 or the typical amount of the 21st chromosome. So this has all been in a petri dish, but there's been lots and lots of news and reports about this because it obviously has, grave implications for future. But it's pretty exciting, and I just want to mention this because it exists, but we're really going to spend the rest of the time focusing on Down syndrome in the here and now. So non-invasive prenatal tests. Many people in the audience might be familiar with this. So if you have a female patient who is pregnant and they're of advanced maternal age, or they have prenatal first trimester screens that suggest they're a high risk for having a fetus with aneuploidy, they might be offered the non-invasive prenatal screens. So the way it works is that maternal blood, here you can see the fragments of DNA are both red and blue. So maternal blood contains cell-free DNA from both the mom and the fetus. And the cell-free DNA degrades rather quickly, so it doesn't represent a prior fetus. So blood is extracted from mom, and then the chromosomes, little fragments, are tagged as belonging to whichever chromosome. So they can say, this DNA fragment belongs to the 12th chromosome, this one belongs to the 14th, this one belongs to the 21. And when they're done analyzing all of these, if you have an overabundance of one of them, then that's suggestive of aneuploidy, or a fetus with Down syndrome. So this was first put into practice in 2008. This was a paper with 18 pregnant women. They were all high risk for having a fetus with aneuploidy. And they did exactly what we talked about, using something called shotgun sequencing. And you can see here the 21st chromosome. There's an overabundance of the 21st materials, suggesting that there's a fetus with aneuploidy. But as with most things in medicine, sometimes the science gets a little bit ahead of how to use it in practice. And so the Wall Street Journal and Boston Globe have commented on these prenatal tests, because now there are companies kind of racing to get these prenatal tests out there. So tough calls on prenatal tests, companies racing to promote this new genetic screen for Down syndrome, and worries about patient confusion. And the Boston Globe says, new prenatal genetic tests hold promise and worries. So because of this, the governing bodies, so the ACOG and the Society for Maternal and Fetal Medicine, have suggested guidelines for how to present this material to new and expectant parents. And they're threefold. So the one evidence-based resource that's always suggested is something called Brighter Tomorrows, which is a wonderful way, it's a website and a webinar to explain the diagnosis to somebody, so that the healthcare provider can do this in a very conscientious and thoughtful way. The next is a book called the lettercase.org book, which is a really phenomenal book. It was put together by the Down Syndrome Consensus Group, which had input from lots of different providers as well as family members. And it's a very thoughtful book in the way that they've produced it, such that all of the pictures of kids with Down syndrome are actually of kids doing activities. The kids aren't directly looking into the camera. And this was done on purpose because families felt like it was too personal to have the child kind of looking at them in the eyes when the families didn't really know what they were going to do and they didn't know about Down syndrome. So it's a way for them to learn about Down syndrome and see them doing activities, but not necessarily having them directly stare at them. In addition, the book's really balanced, so it gives all options for people. So it talks about termination if that's what's appropriate for the family. It talks about adoption and gives information about adoption lists. There's right now a 6-month waiting list to adopt a baby with Down syndrome, as well as continuing the pregnancy. So if someone goes on to continue the pregnancy, there's this resource from Down syndrome pregnancy. It explains how you can tell other family members and friends about this new diagnosis and just kind of walks you through the pregnancy in general. And then always at this time, the Mass Down Syndrome Society has a program called the First Call Program, which is parents who have been trained about, they usually have a child with Down syndrome, but are trained on how to talk to new and expectant parents. And this is an amazing resource that we can offer to families of all different ethnicities, backgrounds. But usually we try to connect parents with someone from the First Call program once they have a potential prenatal diagnosis. All right, jumping into the real meat of the talk, which is adults with Down syndrome. And you can see here Dr. Flores and Ben, who's going to be talking a little bit later. And this is a pretty classic photo of Ben teaching Dr. Flores. Okay, so we're going to do 4 cases. The first one is the lengthiest, so bear with me. So case 1 is change in behavior. So this is one of the most common things we see in the clinic. This is a 23-year-old female who has Down syndrome. She graduated from high school a year ago. She's now in a day program. She was described as extremely social in high school. She was always invited to the party. She had tons of friends. And then the past year, she's really become forgetful, aloof, withdrawn, and she's also reporting increased fatigue and some weight loss. So how do we know what to do with this person who has Down syndrome and this change in behavior? So we get information about guidelines from a few different sources. One is Dr. Brian Ciccone and Dennis McGuire are the leading experts in Down syndrome for adult care. They run a clinic out of Chicago where they've seen over 5,000 unique individuals with Down syndrome. And this paper is from 2011, goes through all the different healthcare guidelines and the rationale. This book is also a wonderful book about the guide to good health. We often suggest that parents get this copy of the book. In addition, the National Down Syndrome Society has guidelines for all ages, so ranging from pediatrics to adult, but these are the adult guidelines, and we'll go over the specific ones in a moment. All right, so this is one of our patients who does not have a change in behavior, but I like the photo. So we're going to start with our checklist. And what we do is when we have someone with a change in behavior, because it can kind of be overwhelming for a parent, they just want their child fixed. They want to understand why are they different than what they were before. And it's not as easy in somebody who has an intellectual disability. So we basically pull out this checklist and we go through our thought process. So the first is excluding medical conditions. So if somebody with Down syndrome has trouble hearing or seeing, they might not necessarily tell you this, but it's going to be something that can really affect the way that they interact with the world. So we screen for these regularly. Thyroid, celiac, constipation, obstructive sleep apnea, and pain. So we'll go through them in more detail. Maximizing expressive language skills is key. So if you're unable to communicate how you're feeling, that can absolutely affect your behavior and can lead to frustrations. And then lastly, we think about mental health conditions. All right, so hearing. So we have a very close relationship with the ears, nose, and throat doctors and the audiology department at Mass Eye and Ear, because when anyone comes in for an appointment to see us, they get same-day audiology and ophthalmology services. So around 65 to 90% of adults with Down syndrome have hearing loss. It's usually a combination as they get older of mixed hearing loss. So conductive hearing loss is incredibly common. They have small ear canals, they've had frequent ear infections when they're younger, they get wax buildup in their ears. As well as sensory neural hearing loss, which is more of the nerve kind of breaking down with time. And what we do is we evaluate every 1 to 2 years, closely follow them. We suggest that they see their primary care doctor for ear checks so that if they have a lot of wax buildup, that's being cleared out. And then hearing aids is something that is very helpful for the sensory neural hearing loss. Next medical problem is vision. So up to 100% of adults with Down syndrome have some sort of eye condition, ranging from nearsighted and farsightedness. Lots of kids have nystagmus and strabismus that can go on to lead to amblyopia when they get older if it's been untreated, and then cataracts are increasingly common. So usually we suggest testing every 1 to 2 years. So thyroid's interesting. I think everyone knows that thyroid's associated with Down syndrome. This was a study that I just wanted to mention. It was a 15-year follow-up study, so it's the longest study to date of thyroid status in adults with Down syndrome. And they looked at around 112 patients, and what they found was that at any year, around 80% of people were euthymic, and that of those who had subclinical hypothyroidism, the majority continued to have subclinical hypothyroidism and didn't progress to overt hypothyroidism. So this paper came out in 2011. It hasn't changed the guidelines yet, but based on this, they're suggesting maybe we actually increase the interval for screening. That being said, I would say that any patient that comes to see me has some symptom concerning for hypothyroidism, whether it's lethargy, obesity, or something to that effect. So we do continue to screen every year. And as we'll show you a little bit later, it's actually pretty impressive that if we treat individuals with subclinical hypothyroidism, a lot of them do have improvements in their mood, their affect, weight loss, sleep, etc. So the numbers that we're using are for typical individuals, and so maybe individuals with Down syndrome might have to have their thyroid in a lower range. So celiac disease is incredibly common in the general population. It's more common in individuals with Down syndrome. It's not fully understood why, but around 10% of adults with Down syndrome have celiac disease, so it's around a 6-fold increase. There aren't guidelines to check annually. We go based on symptoms. So if someone has new diarrhea or constipation or severe behavioral problems and they're really not very verbal or communicative, bloating, abdominal pain, vomiting, those would be an indication to check for celiac. We just do the blood test usually, and then if that's positive, we have a nutritionist and a dietitian in our clinic, so we discuss what celiac disease is, and then usually suggest an intestinal biopsy to confirm the diagnosis, because what we're learning is that there might be maybe an increased risk of false positives for the TTG and IgA in this population. It's seen in individuals with with diabetes, so it might also be seen in individuals with Down syndrome. So we usually do suggest they go on to get an intestinal biopsy as opposed to going completely gluten-free. So last is constipation. So constipation is really common in young children with Down syndrome, but we also see it in older individuals with Down syndrome. And if you have an intellectual disability, it can be kind of hard for you and your parents to actually know how often you're going to the bathroom, what does your stool look like. You'll just usually get the, yes, I go to the bathroom. So sometimes when someone has severe behavioral issues and they have some stomach bloating, we do get an x-ray. And so you can see here, this is the before, where there's lots of stool here, just a little bit of air. And then we give them a weekend of Miralax clean out, which is a lot of fun for the patient and their family. And then their after appearance. So you can see lots more air here and the person feels a lot more comfortable. So a lot of times this isn't necessarily the whole answer, but this is part of the problem, so we make sure to fix this. So obstructive sleep apnea is common in adults with Down syndrome. The American Academy of Pediatrics actually suggests that all children before age of 4 get a sleep study. With adults, we don't know the exact numbers, but some small studies have suggested that around 90% of people have sleep apnea, so it's incredibly common. And so why is that? It's probably that they have a low tone, a small mouth, a large tongue, and obesity is an increased risk factor. So we ask about the usual things: snoring at night, falling asleep on short drives. Some people will describe that their loved one sleeps hunched over in the bed. And we've been working closely with Dr. James Mojica from pulmonary and sleep medicine, and we order a sleep study, and that's really the only definitive diagnosis right now. If the person hasn't had their tonsils and adenoids removed, we consider that, and then CPAP is really the treatment of choice. So because this can kind of be overwhelming for people, and families have a lot of reluctance to bring their child or their loved one to a sleep study, our research coordinator here is working on creating a social story so that it kind of shows pictures to walk people through. And Ben was very kind to be our actor. So you can see Ben here with all of the sleep apnea props on his face. So the last medical problem that I wanted to discuss is pain. So there's an increased threshold for pain and a decreased ability to communicate pain. And as individuals get older, arthritis becomes incredibly common. So we see 30-year-olds with pretty significant arthritis, dental disease, reflux, constipation, and urinary tract infections. So parents have to watch for kind of subtle signs of expressing pain: grimacy, pointing, sweating, holding a limb. All right, so we've gone through the Down syndrome behavioral checklist in 10 minutes, although it takes a lot longer in clinic. And now we talk about maximizing expressive language. So when kids are in school, they have intensive speech services, and then unfortunately they turn 22, and a lot of things just kind of fall to the wayside because there's just not as much support. So we're very lucky here because we have a speech language pathologist who works with our patients, and there is also a pro bono service associated with MassGeneral for speech language pathologists who are learning to be speech language pathologists, and they will offer some additional services for free for our patients. So that's been a great thing that we're trying to use more for individuals who are willing to work on their speech. but being able to speak or have some way to communicate your needs really certainly helps your behavior. And then lastly, we think about behavior conditions. So the myth of Down syndrome, I think, is most people who don't know a lot about Down syndrome think of people with Down syndrome as smiley and perpetually happy. And the reality is that individuals with Down syndrome, they are very sensitive. They feel things longer, stronger, harder, heavier, etc. But they're at a higher risk for mental illness, such as obsessive compulsive disorder, depression, and anxiety. So before you can diagnose somebody with a mental illness, you have to understand what is normal for this population. So developmental age is key. So getting IQ testing or neuropsychological testing can be really helpful. A lot of times, because individuals with Down syndrome are so social and charming at times, it can overestimate their developmental age. So you might then be having conversations with them that are above their developmental level. So it's important to understand that and have a context. The next thing that is very normal, but we always get parents concerned about this, is self-talk. So most of us hopefully process things in our head as the day. Some of us have colleagues who talk a lot to themselves out loud, and that can be frustrating. But individuals with Down syndrome commonly do this. They talk out loud to themselves all the time, and it almost seems like, parents will say, it seems like they're having a conversation with somebody else in the room. There's this back and forth banter. And when I was first being introduced to the world of Down syndrome, which was not that long ago, I went to the annual conference in Worcester. And I saw a family get on the escalator, and they're sort of hurrying their daughter along, and she's moving as a slow pace. You can't rush people with Down syndrome. They go at their own pace. So she's slowly getting onto the escalator. She's just a few feet in front of me. Family's all the way up there telling her to come on. And she's talking to herself. I don't want to go to this event. Why do I have to go to this? You have to go to this event. I don't want to go to this. You have to. Back and forth for the whole escalator. I couldn't pass her. She was just like in her own world. And I felt so bad for her. I'm like, why is her family neglecting her, this poor kid? And little did I know that this is just how she processed things. And an hour later, I see her engaged with a group of teenagers, doing some activity, laughing, having the best time. And her parents were smarter than me, and they knew that this was just the way that she was processing the event. So self-talk can be really normal, and we have a great handout that we give to families. There are situations where the self-talk can be more detrimental, and so if you start to hear a lot of violent self-talk or disparaging self-talk, that would be something concerning. But overall, it's a good processing tool for individuals. The next big area of sort of quirks is sensitivity and delayed grief response, as well as difficulty understanding time concepts. So a patient of mine in the primary care clinic was sitting there telling me how happy he was. He's a dancer. He was talking about his recent performance, and then he said, started to hysterical cry, like bawling, crying out of nowhere. And my first reaction was, oh my goodness, what's going on? So I got him some tissues. I said, what's the matter? He said, my dad died. I just wish that my dad was here. And his sister, who was sitting behind him, looks at me, and when I grabbed the tissues, I just said to her, how long has your dad been passed away for? And she just lifts up her hands like this. And I was like, okay, so it's been 10 years. And so he felt that as if it had happened yesterday. And I think we all can feel that at times, but most of us can kind of keep it inside of us, where for him, it was just so real and visceral, and he cried. And he quickly got back to his dancing. We were able to quickly change topics, but if I didn't know that about someone with Down syndrome and know that that's just part of who they are, I might have been a little bit more concerned that he was having problems with grief and processing this. So lack of flexibility is incredibly common. So they like routines and sameness. They're sort of called grooves. So a little girl that we saw the other day in clinic, she loves her macaroni and cheese. She'll only eat it at lunch in school. She will not eat macaroni and cheese at home, only in school. She ate all these different vegetables at school that they offered her, but she won't eat them at home. So these are things that she only does at school. So that can be hard for parents to deal with, but that's part of the extra 21st chromosome. There's a little bit of stubbornness that comes along with it. Concrete thinking is incredibly common. So if you say to someone with Down syndrome, call me anytime, and you actually give them your phone number, they will call you anytime. So one of our patients was in a Zumba dance class, and she loved the Zumba instructor. The Zumba instructor kind of bonded with her. She said, call me anytime. 3 a.m., calling the Zumba instructor. Not appropriate. They also have a slower processing speed, so just trying to be aware of that and making sure that you give a task and you have a follow-up for it before you list off 3 or 4 different tasks. There are certain memory strengths and weaknesses. So Ben is our navigational aid through the clinic. I have no idea how Yaki works. It seems like a ginormous maze to me. I get lost every time. But I'll ask Ben to show me where the bathroom was, and he can. He takes our patients everywhere. And then there's some weaknesses with some factual aspects of memory. So the book that really sums this up, and we call this the Bible of Down syndrome, is the Mental Wellness Book of Adults with Down syndrome. And this was written by Brian Ciccone and Dennis McGuire, the individuals from Chicago. And they really promote mental wellness by addressing some of these personality quirks so that you can understand that these are just quirks and a part of who these individuals are. And then also being aware of the increased susceptibility to stress. And they highlight the 3 aspects of mental wellness in adults, which is getting good health care, which is what we try to provide, work opportunities, so vocational skills, and getting people plugged in with DDS, and then social opportunities to engage with other individuals and continue that social dialogue. So let's follow up on our first patient. So she ended up having a sleep study which showed severe obstructive sleep apnea with an apnea-hypopnea index of 41. And then she had celiac testing that was fluidly positive. So her change in behavior was likely somewhat due to her medical issues, but then in talking more with the family, it appeared that there were lots of other social stressors going on at home, so we found a therapist for her. So hopefully those things will help. All right, moving on to our next case. So this is one of my favorite ones. This is a 24-year-old man with Down syndrome who just came in to get a tune-up. And so we see this a lot, and these are the fun ones because they don't have a lot medically that's going on, but it gives you an opportunity to talk about all the other fun stuff. So he had a repair of a membranous VSD when he was 7 months old. He recently ran a 5K, so his heart does not seem to be a problem. He's employed at CVS and he loves his job, and he spends time with his girlfriend of a year, which he was very proud about. So when we see individuals for routine care like this, we do the usual health maintenance recommendations, make sure they're up to date with the typical population as well as the things that are specific for Down syndrome. And then we talk about these aspects. So transition from pediatric care to adult care. So the number of 20-something-year-olds that I see who still have a pediatrician, and the parents will say they're basically waiting for their pediatrician to either retire or die, is amazing. And sexuality is not something that people really talk to very much with individuals with intellectual disability. We also counsel about obesity, osteoporosis, and risks for cardiovascular disease. So a common question that we hear is, how do I plan for life after high school? So how do you find an internist? That becomes part of the process. Guardianship is really huge. So once an individual turns 18, they are their own legal guardian. And what that means is that if they had a positive screening test for celiac and they need an intestinal biopsy, this person is the one who has to sign the consent form. And that's not always, for the most part, there are some patients who can be their legal guardian, but most individuals need to have somebody who has a little bit more control over the medical nuances and can explain this to them so that they can consent. We also talk about day programs and further education, living situation. Are you going to stay at home with your parents? Or are you going to go to a group home? And then promoting independence is key. So we had a focus group earlier in the month on transitions and transition readiness assessment. And one of the patients there was with her mom. She was very quiet in the room, very polite and sweet, didn't say very much, but clearly she took something home, which is that she wanted to call and make her next appointment by herself. So she's 16, so we're going to attempt to play this video clip. Oop. Or voice clip.
My name is Leslie Mack, Leslie, and my last name is Mack, M-A. I would like to make an appointment with Dr. Scotto.
She then goes on to tell her phone number, so I'm going to switch over that. But she was so proud of herself that she called and made an appointment by herself. And it took some practice, but it's really impressive. Mom could have just made the appointments for her, but she's taking some more ownership of her care. So there are a lot of great resources. We're trying to get these resources up on a website so that everyone can have access to them, but this is from the Department of Developmental Services, or DDS, School Days to Paydays, and is a really nice pamphlet that goes through employment planning guide for individuals with intellectual disabilities. Massachusetts has the ARC, which has different chapters depending on where you live, and this is a great resource also for families. There are people that can sort of help with, what group homes are in this area, are there day programs, is there a summer camp that my child can go to, etc. So how do I talk to someone with Down syndrome about puberty and sex? So common questions are individuals with Down syndrome fertile? And the answer is that men with Down syndrome are usually infertile, but women with Down syndrome can be fertile, so that's important to know. Do individuals with Down syndrome have sexual feelings? Yes, they absolutely do, and if we ignore them and don't discuss this, that can lead to lots of behavior issues as well as inappropriate behavior. And how can a person with Down syndrome be protected against sexual abuse? So having parents be aware of this, incorporating this into the transition planning curriculum when they're in high school for life skills training can be very useful. And we always suggest that people get the Gardasil or the HPV vaccine for both men and women to protect them. So this is one of our patients who came to see us, and then later that day she got engaged. And her parents were very well versed in talking about these topics with her. But if they weren't, we have a bunch of resources that we can suggest about puberty and the developing body and sexuality. In addition, there's this curriculum that a lot of schools use that's called the Circles Chart. It's very visual based. It's kind of the inner circle is where the patient is, and they can label who's in their inner circle, who they can hug, who's all the way out here, such as a stranger. And then, who knew, there is something called a sexologist for people with intellectual disabilities. We have indeed Skyped with her. She's lovely. She is our go-to person for people who are really struggling with their sexuality and potentially at the workplace doing inappropriate things. So she does phone and Skype consultations for anybody. Obesity is incredibly common. Over 90% of our patients are obese. This is due to a decreased metabolism, and they tend to eat a lot of calories. So we have our patients see by our dietitian at every single visit, and we suggest increased recreational activity, a lot of portion control, and treating the underlying medical illnesses. So these are 3 separate patients, and what I want to highlight is that compared to my primary care clinic where people stay exactly where they are or they continue to gain weight despite what I think is my attempting to be motivating, individuals with Down syndrome can be very successful, and that's partially due to their perseverant and determined personalities. So the interventions here, you can see that this patient had hypothyroidism, so they were started on thyroid supplementation, and they had weight loss. This individual in purple had thyroid as well as CPAP for sleep apnea, and then this individual started Weight Watchers and had CPAP. So really impressive gains. Osteoporosis is an interesting medical issue that's affecting more and more individuals with Down syndrome at a younger age where they're presenting with fractures, and if you do a DEXA, they'll have a T-score of -2, -3. And the etiology of it is different than in the typical population. So they have low bone turnover, which basically means that bisphosphonates are probably not going to be as effective. And so there are ongoing studies to look at what the effectiveness is. In the meantime, we do get a bone density test in their 30s to kind of see where things are. And we always encourage lots of exercise, calcium, and vitamin D. So cardiovascular disease, around 50% of children with Down syndrome have cardiovascular disease, they have congenital heart disease. Of that 50% are AV canals. And then those who do not have congenital heart disease, they are still at an increased risk for conditions like mitral valve prolapse. So this is something we always warn people about, and we listen at every year visit. And unfortunately, they have a decreased risk of atherosclerosis, which isn't really clear, but it's very rare for someone to die of a myocardial infarction. So on to our third case, which is neck pain. This was a 27-year-old with Down syndrome who couldn't speak at all and had hearing loss. His parents were concerned that he was having neck pain. When they went to pick him up, he would grab at his neck. He wasn't walking as much as he used to. He preferred to sit in his wheelchair, and he was really agitated. So in terms of neck pain, everyone always thinks of Atlantoaxial instability. So just as a reminder, this is the odontoid or the dent, which sticks up and kind of is nuzzled into the C1 vertebrae, and this is the C2 or the axis. Individuals with Down syndrome have overall hypotonia and ligamentous laxity, so that can cause the odontoid process to not stay put and affect the spinal cord. So in terms of how prevalent atlantoaxial instability is, it's seen in around 15% of individuals. So it's very rare, but it's dangerous. And the test of choice is an x-ray of the spine. However, we've learned through studies that an x-ray really isn't that helpful because at one point in time it can be normal and then you check it again and it's abnormal or vice versa. So C-spines don't predict who's at risk and normal C-spines don't provide reassurance. Routine C-spines are not recommended if someone is asymptomatic, so we don't screen with that any longer. But if someone wants to participate in Special Olympics, they usually still require them for participation. So instead, what we do is provide this as a handout to parents and really educate them at every visit to be mindful of changes in gait, changes in the use of their arms and hands, changes in bladder or bowel function, neck pain, new onset weakness, and always check a good neurologic exam for hyperreflexia and strength. So this patient, he had a CT of his head and neck that showed degenerative disc disease with mild central canal stenosis and facet degeneration. And he ended up getting an MRI, which then showed intervertebral discs at C3, C4 with degenerative changes in myelomalacia, which is a softening of the spinal column. So his neck pain actually did improve pretty significantly with naproxen. They tried to put a C-spine collar on him, but he couldn't understand why that was happening and really didn't tolerate it. So he's currently being evaluated for a possible posterior fusion. So in his case, it's really more degenerative disease of his neck as opposed to Atlantoaxial instability, but this is something that we always think about with individuals with Down syndrome. Okay, the last case is cognitive decline. So this is different than the behavior changes. Behavior changes we see a lot, and those are due oftentimes to reversible things or a mental illness. Cognitive decline in individuals 40 and up. People are very concerned about Alzheimer's disease, although most of the time it's not that. So this was a 47-year-old who I saw who was really pretty healthy. He had hypothyroidism. He lives with his 89-year-old mother. He was very high functioning, but the last 2 years he's had a decline in his level of function. He was previously obsessed with Elvis Presley in a healthy way, and now he's constantly talking about fighting and imaginary friends. And his mom found him outside once at 2 a.m. pretending to fight with friends and engaging in self-talk. And in this situation, clearly this is a self-talk that's a little bit more pathological. Wasn't sleeping very well, losing weight, less interested in food, and his mom's very concerned. So, again, there's an increased risk of Alzheimer's disease, but we always rule out the reversible causes. You can see here that this is the individuals with Down syndrome, so we usually start seeing it after age 40. And there's different percentages depending on what study you look at, but it is certainly not 100%. Everybody with Down syndrome will have evidence of amyloid plaques and neurofibrillary tangles, and that's because chromosome 21 has the APP protein, which is responsible for that. So we go through a similar list of cognitive decline behavioral checklist. I just want to point out this is a patient of ours who was our own guardian, and she's consenting here with our research coordinator. And she is around 50, but she has evidence of premature aging. So around age 45, 50, you can suddenly see that individuals with Down syndrome really look a lot older than their stated age. But she was being evaluated for possible Alzheimer's disease as well. So we go through the medical stuff, then we work on social health and mental health. So common questions are, do all individuals with Down syndrome develop Alzheimer's? And the answer is no, but autopsy will show the NF tangles and plaques. The average age of onset is usually in the late 40s. And then common signs, so similar as the general population, which is a decline in skills, which can be hard to discover in somebody with Down syndrome. So what we do is anybody at between ages 28 and usually 34 gets a baseline neuropsych testing to get a sense of what they are at baseline, so that if they show changes or decline in skills, we can get a repeat testing and have a point in comparison. Gait change, seizures are incredibly common, and dysphagia. And then the medical conditions that we ruled out were shown on the other page. So this is a pamphlet that was produced by the NDSS on aging and Down syndrome. It comes in English and Spanish. You can order it online. They have really great pictures. Most of the adults with Down syndrome just like to flip through and look at the pictures, but it's really useful for the family to go over the premature aging, the importance of getting eyes and ears checked and the routine screening, and really debunks the myth that everybody has Alzheimer's disease. Alzheimer's Association has a chapter in Massachusetts that's really active in the Down syndrome population. And so this is a great resource for regular patients who are struggling with memory issues, as well as individuals with Down syndrome who are struggling with memory issues. So our patients are really leading fun, full lives, and they're a joy to work with. So I wanted to talk a little bit about the clinic. So we have 4 physicians I see kids and adults. Dr. Skotko is the clinical co-director with me. He's a geneticist by training, and he sees the pediatric patients. Dr. Flores sees adults, and then Dr. Jess McCannon is a pulmonary critical care attending, and she sees adults. We also have a robust cast and crew, which consists of our program coordinator, our social worker who's in on all of the visits, Ben Majewski, who you'll hear from in a moment, and then our new nutritionist, which has been wonderful to have. We have a research team as well, which is Mary Ellen and Christiane Shar. And then we have 5 clinics. So we have a prenatal clinic, which is just usually one of the physicians, and then our genetic counselor and social worker, where we're meeting with families prenatally to discuss their presumed diagnosis of having a fetus with Down syndrome. It's usually an opportunity for them to ask lots of questions of what it is like to have a child with Down syndrome. And in many situations, families are really torn about what to do. And in some situations, they just want to meet us, but they know that they want to go ahead and keep the baby and go on with the pregnancy. We have an infant and toddler clinic, and the highlight of the infant and toddler clinic 0 to 5 is that we have these 3 folks who are PT, OT, and speech that perform a full evaluation on the children. And then they're also, again, seen by audiology and ophthalmology. 5 to 13 is where we have psychology first enter the arena because some behavioral issues start to appear. 13 to 21 is our transition age group, and we focus on readiness assessments and promoting independence, guardianship as well. And then we have our adult clinic, which we've talked about. So if you want to refer, this is the website, massgeneral.org/Down syndrome, and that phone number goes to Tommy, very lucky. So I just wanted to thank you all for your attention today. I hope I've given you an overview of adult care with Down syndrome and also inspired you to welcome these patients and this growing population into your clinic. And now I have the pleasure of welcoming my colleague, Ben Majewski, who's our resource specialist in the clinic, and he's going to talk a little bit about his life and his role in the clinic.
So thank you. So the biggest stuff that I for the presentation. Again, my name is Ben Majewski, and I grew up in New Massachusetts. I completed my my public school education in June of 2012. I attended the Transitional Scholars Program, which supports students with developmental disability at MassGeneral Community College. I started my 4th year there in September of 2013. In addition to my job as a resource specialist here at MassGeneral, I work on the grounds crew with the Boston Red Sox on Thursdays and Saturdays. I'm a busboy at a restaurant in Newton. It's an restaurant called O'Hara's. I also volunteer in the dining room at Rose's Place, a shelter for women. I have the same position for 2 years at Children's Hospital. These similar to the one I have now at MassGeneral. I like working with families. I enjoy public speaking. I was the keynote speaker in the March 2011 Massachusetts Autism Conference in Worcester, Massachusetts. I spoke at the Developmental Interest Group of Washington, D.C. in 2012. I give talks, oh yeah, this side. I give talks to the elementary school students with the Understanding on Differences program in Newton, Massachusetts. So, you might be wondering what I do here at MassGeneral. My job responsibilities are to welcome and escort families to medical appointments, meet with new patients using an iPad to give them information about healthcare issues or resources for the other dormant with Tommy, our program coordinator. Help with office work like mailings or making copies. Visit patients who have autism with Helen, our social worker. When Lauren Potter came from a TV show called Glee, came to visit MassGeneral. I was able to take Lauren to visit one of our patients as well. I give out toys to children and pick up at the end of the day. Growing up with Down syndrome means that some people might look at you differently, but you can still do a lot of things as other people do. Sometimes you need a little extra help. I think it's important to hire self-advocates to work in Down syndrome programs because they can see them as role models, and it helps them to see, it helps parents to see this other daughter to have a bright future, and thank you.
Thank you. If you guys have any questions, I'm happy to answer.
Dr. Schwartz. That was a great review. For the parents, because the parents, as the patients get older, the parents are always substantially elderly.
Yeah.
So what sort of resources do you have for them?
Yeah, that's a challenge. A lot of times siblings step in and help out. Some individuals go on to group homes, and we've had great experience with group homes in terms of like how caring they are for these individuals and how well they do in the programs. But it is always hard, like in that last case of that 89-year-old mother, he was sleeping at bed at night staring at her, and probably that was contributing to some of his anxiety knowing that mom was getting older. So we try to just have these conversations early on about who would the person live with and what are your plans. Yeah.
Simon? Yeah, I'm curious that the neck pain case, it didn't turn out to be Atlantoaxial instability.
Yeah.
If it were, what does one do in that?
So you can do activity restrictions, or if the neck pain is actually contributing to weakness or hyperreflexia or symptoms, then they do a posterior fusion, so surgery. So the end would probably be similar. It's just that we're seeing more and more degenerative disease than just typical Atlantoaxial instability.
Dr. Spitzer?
You mentioned a research aspect of your program. I was wondering what the mission was in regards to research, and are there issues that inform it? So,
Yeah, I will turn towards the research, senior research, Mary Ellen.
Hi, I'm Mary Ellen, I'm the research coordinator, and we are looking at a couple of things. One is obstructive sleep apnea, which is obviously very, very common with people with Down syndrome. And what we're doing is trying to look, the standard is to have a sleep study to diagnose people with Down syndrome, well, anyone with obstructive sleep apnea. And we're trying to look at 6 predictive factors other than a sleep study to see if we can diagnose kids or adults with Down syndrome. The gold standard for children with sleep apnea is to do a TNA. For most people, it's CPAP. The problem with CPAP, it's very difficult for people to comply. Normal people with Down syndrome have a lot of difficulty with sensory stimulation. So we're working on one study with that to see exactly how we can approach that. The 2 other studies that we're going to be starting in late summer and fall is using new drugs from the companies Elan and Roche to see if we can improve cognition. As Allie pointed out, there's amyloid plaques in the brain, and hopefully what these drugs will do is create a healthier environment in those neurons so there can be transmission and improved language ability, learning ability, and memory. So that's where we are right now. We also have a Down syndrome registry, which has never been created before. There's 5 institutions working with us, and we're just gathering data, basic data on people with Down syndrome, age, and the 3 things we're focusing on right now are celiac disease, thyroid disease, and
those 2 for this year.
those 2 for right now. We intend to broaden that so that we can create guidelines for medical care for people with Down syndrome. And our research team will continue to offer opportunities. Up until now, there have been no clinical trials for people with Down syndrome. So it's a pretty exciting time, and as Dr. Schwartz pointed out, the article in Nature was just transforming for this community in many, many ways. But we're excited to start in the fall with these 2 clinical trials. We do have a research website. It's on this, if you go to the Down syndrome program, there's a link to us on that website.
Holly, you make it clear that competent care for patients with Down syndrome is labor-intensive, multidisciplinary, resource intensive. Are there insurance or issues? How does one support this, especially since these patients are not Medicare?
So some of them are, but it is very resource and labor intensive, and I'd say that the hospital supports us immensely, but a lot of our positions, our social worker, Ben's position is funded through the goodness and generosity of families who have individuals with Down syndrome. So there is a big role for philanthropy within the clinic. We see them as consultants, so we're able to bill at a higher level, but I do see a lot of patients in my primary care clinic with Down syndrome, and it is very challenging in a 15-minute visit to get accomplished what we can do here with a multidisciplinary team in a 45-minute visit. Yeah.
Question? One final question?
We work with Alison T and Adolescent, and so we've watched this over the past few years evolve from really Jose doing this kind of alone to things growing on a trajectory. This is the definition, right, of care redesign. We have taken, you have taken for Down syndrome program existing resources, clearly identified additional needs. We used both support from the hospital administration because we've proven your point in what you can do, and then used philanthropy to get this to happen. And I will tell you that some of our patients who are now quite old, you know, they're the population we're talking about, whose parents are now 80, they're 40, they're starting to become introverted, who literally cry in our office to simply know that your program exists, even though they may not yet be availing themselves of what you have. And so I think we've come very far. But when we look at this from a perspective of care redesign in this hospital, to follow the model of how you've done this, I think is something that we should all think about in our own division department, because it's really quite impressive. And I don't think everybody understands how much work you guys have put into this.
Thank you very much.